Hey guys, my name's Dave Neuber, and this is Dr. Larsen, a long-term veteran that we've been working with for many years, and I can honestly say that of all the cases we've done over the last 30 plus years, I'm going to post them as the top 5% as being perfect retraction. You know, it doesn't matter if you're going to do digital or traditional analog impression, which I think Dave has ultimately been, as I said, a master in this area. What we're going to do today is just an example of what works. Okay, there's lots of different ways you can explore with retraction. We know that, but we're going to show you what works day in, day out, whether it's a last molar or you know, an anterior tooth. So just as a quick introduction, that's what our goal is. And Dave, do you have anything you want to add to that?
Yeah, I don't think so. I think you've covered it. So yeah, we're just gonna show the technique that I've used for years, and it's been consistently good, as you know, from what I hear from the lab. So yeah, that's great. Yeah, we got good results. So yeah, so all right,
right on.
Hi, this is Sean. We're just gonna welcome him into the chair here and get him frozen, and he's gonna be famous.
How did you find
I don't know. He was down at Five Corners.
Yeah.
And
That's ages
my
ago.
mom took me there. I've been here since.
Well, at least you got all your teeth still.
Yeah.
Just had a build up, blue core build up done, and then endodontics done through the blue core. So we're just leaving all that in place because it's been bonded. The core's been bonded as well. So we're just gonna get it frozen. So we've got some topsoil on. So I'm using lidocaine, 2% lidocaine. 1 in 100,000 epinephrine. It's kind of this anesthetic that I use most of the time, 99% of the time anyway. So one of the things I know for packing cord lingually, one of the cues that I use for whether we've got adequate anesthetic or not is it's got to blanch the tissue all the way from the mesial to the distal. So if you could see inside there now, anesthetizing it, you have to keep that in there long enough and pressure long enough to have that tissue blanch. You can see it's blanching up onto the palate now. It's into the mesial embrasure, but it's still not completely anesthetized on the distal. So I'm going to move back now into that anesthetized tissue and just add a little bit at the back. One of the things that makes packing cords so much easier is to make sure you've got adequate lingual anesthesia, particularly on the upper teeth. Patients appreciate that. Okay, so that's all we're going to need. It's an endodontically treated tooth, so we're not worried about any symptoms coming from the pulp. So we'll just give that a minute and then isolate with a rubber dam.
If it was a vital tooth, how do you manage that as far as, you know, what's too much and what's not enough? I mean, our goal always is to see 1.5 to 2 mils occlusively reduction, but when do you say that's all I can do?
Well, it's all anatomical, and it depends on the age of the tooth, the patient, the clinical situation with the tooth. So radiographically, you can tell where the pulp ends and how much tooth structure you have between the top of the pulp and the preparation. So all of those things you can take into account before you start to prep the tooth. You need to really know what you're dealing with before you even touch the tooth with a burr.
Yeah. Awesome.
So we're just going to start the occlusal reduction. I use a wheel diamond to do that because I know the depth quite easily, and it's easy to put it in alignment with the occlusal plane or the crust inclination. I find it much easier than using a straight diamond. It's quicker. So I don't get near the interproximal surface here with a wheel diamond because I can easily cut that crown next door if I'm too close. So next step, I just clear the interproximal area. And when I'm preparing, I don't look at the burr, I look at the tooth next door. You know, I'm keeping a little bit of an isthmus of material. So again, I don't hit that crown next door.
What diamond is that one?
This is an 016. Just, we're going to be doing a TFM on this with a fine gold color margin. Again, it's the same as what's next door. I don't know if you can see that. And again, an endo-treated tooth. trying to get as much clinical crown coverage, particularly for sawing here. You got a propensity for wood cherry, so you want to cover as much of the tooth as you can and give enough strength. So once that's done, I just do the gross reduction of the buckle and the lingual. And again, I'm going to keep this away from the gingival margin when I'm doing the gross reduction until I get the first cord in there.
Oh, okay.
So I don't want to go too close because you can really tear up the gingival margin and create more problems for yourself later. Okay, so I've got 3/4 of the tooth gross reduction. I'm just going to do the distal now. Sometimes I'll pull the burr out a little bit because it's a fairly short burr. So I pull it out of the head of the handpiece just to give me a little bit more length to get to the back of the tooth and still be able to see. I find that if I leave it in fully, the head of the handpiece will block my nerve root. So it's a little trick to be able to get back to that distal area of the tooth and be able to see it clearly and be able to define the margin. Again, keeping it away from the gingiva just about a millimeter until you get that first cord in later. So with this tooth, we're going to have to take the clamp off, obviously, to get that retraction cord in.
Right.
So I don't know if you can see that now. It's kind of gross preparation done. Got a little bit of bleeding interproximally where I did that first level of reduction, but I have to get down close enough to be able to get the cord in. So you have to get enough clearance from the tooth next door to be able to put that retraction cord in. So in that area we did cause a little bit of gingival trauma. Just give them a little rinse. So this is the cord that we use. It's an Ultra Pack. It's a braided cord. This is the number 1, and then we'll put a number 2 in after the second cord. So.
Is that submersed in anything or so?
It is. It's submersed in hematite.
Yes.
Yeah.
So a little side note I want to point out is gloves. We've actually seen a lot of gloves have a layer of talcum on them that retards the set of impression material.
We use all powder free.
Yeah.
And just I want to put a side note to that because in one brand that we did see was called, believe it or not, Ocean gloves.
Oh, I've seen those.
And literally one of our clients, until I actually went there, put the light body on the glove. It
Did
had
not
a
set.
smear layer and it never set. Yeah, so it's very important,
Seen
just
that.
as something like that can be.
Wow. Yeah, I didn't know that, Dave.
Yeah.
That's cool.
Is that instrument that you're placing cord with pretty common out there, Dave?
It is, yeah. It's just
Yeah.
a standard cord packing instrument. I like them because they're a little bit narrower.
Very fine.
And then they got a little bulb at the end that's it's easy to direct the cord in the right place. So we've got the cord all the way around the tooth. I'm just going to knit that little tail. I don't want to double up too much. I mean, there's times when doubling up is okay, but from the feel of this sulcus, there's not a tremendous amount of room there to have more than 2 cords. So just trim that off so that it'll all get embedded. So you can see the gingival tissue, buccally and lingually, has not been marred at all. Even with a clamp, there's no tissue damage there. So I think part of the main thing that I would say is try and get the cord in there before you finish those margins. Most of the time I'll just use 1 cord, finish the margin, put the second one in. But in this case, I'm going to keep it equigingival, and the prep is almost complete the way it is, so I don't have to prep too much more. So I'm actually going to put the second cord in now and then finish the prep. And that sort of gives double protection and also gives me a better view of where the finished margin should be, because where the gingiva will come back to the level of where this cord is coming out from the sulcus.
Dave, I've had some doctors that have asked to do 2 chords technique, and they've responded and said, we feel that it could push the tissue back and it doesn't grow back as nicely. What has your observations been with that?
Well, that hasn't been my experience. I think the upside of putting the 2 chords in is that the impression quality that you get will be considerably better. And as long as you're not too traumatic with putting the cord in. There are situations where I will only use 1 cord if there's very fine gingival tissue, particularly buccally.
Yeah.
You got a lot of recession and, you know, so I might use only 1 cord in that area, or sometimes even no cord, and just put the second cord 3/4 of the way around the tooth and avoid the areas that are going to be problematic.
Yeah.
But if you just avoid a second cord altogether, then you miss out on the opportunity of getting a beautiful impression on the areas that really need it.
Yeah.
To have that retraction.
So the second cord is the same thickness as the first one, or just
Little bit
no,
bigger.
it's a little bit
bigger.
thicker. Yeah.
Oh, a little thicker.
It's a number 1
Number
cord
1.
went in first.
Got it.
Number 1 and number 2.
Okay.
And in some cases, we'll use a number 3 cord, which is quite robust, depending on the gingival tissue.
So that's if it's super sub G and hard to control, or what?
More diseased tissue,
Okay.
probably. It's
Okay.
very not healthy like Sean's here. You know, sometimes it's really puffy, and you need more
Yeah.
more girth to retract the tissue.
Right.
Now we're just going to do our final prep. I'm just going to get you to turn right towards me. For upper teeth, I like to be able to see the buccal margins directly. You can do a lot with a mirror, but for me, like getting the contour, I can look down and you can see how this isn't contoured properly yet.
Yeah.
So I'm going to finish the margin first, and then I'll do the buccal contour of the prep.
Which burr is that one?
Same one.
And I think that's one of the things about prepping that I love when I get a case from you is that one of our biggest challenges is the doctors are striving to get good retention with parallel prep, but a lot of times it creates this real on buckle a really opaque looking facial.
Right.
Because it's tipped out too much.
Right.
And you do a nice job of rolling in.
Well, you can see the contour
Yeah.
of the thick.
Yeah.
And now, if you imagine, it's following the same line.
Yeah.
I kind of took a little bit off of the occlusal edge here, because now I can imagine that's the porcelain that's going to go on there.
Correct.
The burr is going to be basically the porcelain and the metal substructure. So, so that gives you an indication that you've got enough reduction. Okay, I'm just going to get you to turn towards facing that, Sean. So I'm going to go and do the lingual margin. So you can see that cord is popped up a little bit now. So I'm just going to tuck it in again before I prep that. And again, you get used to how much pressure you can use without causing a lot of damage to the attached gingiva or the attachment. So again, trying to keep things as healthy as we can. But that gives you now a better idea of where that lingual margin should end.
Mm-hmm.
So by packing the cord, it kind of gives you an anatomical endpoint.
What the tissue is.
And again, I could leave the margin supergingival,
Yeah.
but in this case, because of the caries potential,
Right.
I'm taking it right down to supergingival. And we're just doing a nice little chamfer margin on there, because it's going to be a metal margin.
We don't see it that often, but every once in a while we see a ski jump type margin where it does like almost a little. How do you prevent that from happening? Or is this just over prepping, or you just make it conscious?
You know, it's also what's happened to the tooth previously. Quite often, interproximally, you'll have caries that's gone very sub G.
Yeah.
And it's nearly impossible to avoid that sometimes, but Yeah, just making sure you got adequate build up and healthy gingival tissue levels before you start. It's never going to be 100% because not all cases are ideal, but
Yeah.
sometimes it's hard to avoid because of what you're dealing with. Okay, so I think we're pretty close. I'm just going to do a final little occlusal prep and get these contours correct, and then we'll check the bite and make sure we've got enough occlusal clearance. So we know we've kind of chamfered this or done the buccal occlusal area of the prep to follow the contours of the tooth. Same goes for the lingual. So you can see this is kind of straight up now. I'm just going to nip off that edge because the porcelain's going to kind of come around, or the casting is going to come around in that area. You need a little bit more room for the porcelain there to be strong. That's going to take the brunt of the occlusion and we'll cut. So get you to bite together. So now you can see we've got adequate, okay, just stay biting. We've got adequate occlusal clearance there. We got about 2 millimeters between the mesiobuccal cusp of the lower tooth and the central fossa of the upper prep. So that's the low point of the occlusion. So. And just bite together again. So I don't know if you can see in there that.
Yep. You know, it's funny, Dave, we always tell dentists when we strive for 1.5 mils, we ask for 2 and we usually get 1.5 mils.
Yeah.
If we ask for 1.5, we usually get 1.
Yeah.
That's usually how it goes.
Yeah.
I mean, sometimes we've got lots of tooth to deal with here. It's still going to be retentive. Sometimes the teeth are really short. Then you choose a different restoration. All right, we're going to be doing a snap temp. So this will, it's interesting because we typically take a little mini impression of the tooth prior to prep, but because we're kind of thrown off by doing the filming, we didn't do that. So I'm going to show you how we make a snap temporary.
Okay.
So this is like if you can't do a little impression prior to, or the tooth's too broken down, or there's missing pieces, you can just mix up a little bit of snap temporary material and we can use that to make the temp. Old school.
Yes,
Mhm.
old school.
That's what we are.
Yeah.
Yeah.
The reason why we like and or endorse the O-bite, it sets up rigid, but it doesn't lock in. So, when we articulate cases together after the bite record, more often than not what happens is it basically, it has a rubbery texture to it. So when we go to squeeze and mount these together, if we have a rubbery material that we mount the cast together, it basically, and it can be hit and miss. But when we have something more rigid, it just clicks into place. And that's why when this sets up, it'll set up rigid, but it won't lock in. Okay, so it's really important, not that you're worried that you're gonna have problems getting it off. Also, we really like it was when you just put the bite record over the prep and just a couple adjacent teeth. If Dr. Larsen,
So you can probably see that.
yeah. If Dr. Larsen would load up the whole arch with it, he can't see that the teeth are in proper CO, and that's why the luxury of just putting it over the prep and a couple adjacent teeth. Another little note is with the bite record when it comes off, if you hold it up to the light, if you can see light shine through it, it will actually tell you that you don't have that full 1.5 mils. That's
This is the snap material.
nice, yeah, perfect.
So it's just a little ball of,
It's in a doughy stage there,
Doughy.
right? Yeah.
just going to mold that over the tooth and bite together. So we'll just let that set on the tooth and then take it off and trim it.
Nice. That's another indicator if it's too thin or not,
Oh yeah, you can see that for sure in the temporary. So I usually take this off and just make sure it's not sticking to the prep part way through. It's still a little bit rubbery, so I'm just going to get them to bite together again. But it's just nice to make sure you got draw, particularly not in this case, but if it's between two teeth, sometimes you can get undercuts, and if you let it set too long, you can't get it off. So if you take it on and off a little bit as it sets, you creates a situation where you can get draw.
And all the while the cord is still in.
Yes.
Do you ever have it where it comes out with the cord when you do that?
It can,
Yeah.
yeah. With the other temper material, it does more
More
commonly.
so, yeah.
But then
This
we're
is
ready
still
to
a
take
little bit
impression.
rubbery, but I'm just going to let it
Final set.
final set there.
Close your lips to them.
And then we're just going to isolate and get the tooth dry, and then we'll do the impression.
So we're doing this.
Yeah. So if you can see, now we've got everything's all isolated and dry. All you see is cord. There's no bleeding. There's nothing going on that's going to affect the quality of the impression.
So the key thing with this material, the honeycomb, Dave, is really encourage doctors to always load the tray first, then
Okay.
do this, because it's different than with the impergum. Impergum, typically it's a reverse, because if you have that sitting on there just a little too long, the light body, it starts to set,
Yeah.
preset. So we're gonna load this first, okay,
Alright,
before
sounds
you do
good.
your magic.
All right, so I'm going to pull this cord out now.
Yeah, you're good to go.
So we just get it all around the margin like that nicely. Insert our triple tray and bite together and just stay biting. That's great. All right, so we'll just stay biting on that now, and I'm just going to mark this temporary.
Now, while that's setting, I want to just point out a couple key factors that we see. When doctors ask patients to bite down, that's a different perception for everyone. Okay, it's a different perception for everyone. Some patients will clench down and then they relax after that, and they don't understand at that initial state that if you relax, it elongates the impression. So this is the devil's in the detail, and a lot of times what we ask docs to do is actually tell the patient, look, it's really important, lightly touch down to your teeth touch, and then hold that position, because if you move while it's setting, you're gonna have a hit and miss fit result. So it's a very important point to point out to the patient before you go, and just that little coaching session. And it really will make or break how consistent the fits will be afterwards too.
So for here, this is the snap temporary. One of the tricks that I use before I trim it, you can see where the interproximal is going to butt up to the crown next door. I take a pen and just color that in, so I don't trim that away.
Nice.
So when I go to put that temporary on, I know that there's going to be an interproximal contact, and I'm not going to lose space there over the time that this temporary is on.
So Dave, speak to me a little bit about what you know and what your experience is when all of a sudden a contact is open. Okay, you get a crown back, it's closed on the model, but it's open in the mouth. Can you share what your experience is? Why is that? Did the tooth drift, or is it from the occlusion? What's your experience?
I think it could be either or.
Yeah.
Yes, there's, especially on an upper 7, I've seen that even after the crown's cemented with a beautiful tight contact, the tooth drifts back, and then you end up with an open contact after. So there are some mysterious things that happen occlusally and things, particularly with a new crown. It might be a traumatic occlusion that helps to, cause the tooth to move, but it does happen. So
I've had some doctors say it could be bone inflammation, and it actually pushes the
sure,
tooth.
it's almost like orthodontics.
Yeah,
Right?
when that happens.
Yeah.
Right?
Mm-hmm.
I was just wondering if that sometimes is from a deeper sub-G prep, that you could get that more bone inflammation that drifts.
Absolutely.
Yeah.
Yeah.
That's all the wild
Mhm.
cards you don't
Yeah.
know.
And teeth that are periodontally involved, that are, the teeth move over time.
Right.
Yeah. All right. And just open. Kind of stuck together. Okay. And you can see now that we've got a nice impression of all of the margins.
That's the beauty.
And always check the opposing. I learned that the hard way. Sometimes I've got a nice impression and forget to check the opposing, and Dave calls me up and said, "Hey." can't do the occlusion without the opposing. So we see we've got a little bit of pull up of the cord on the distal. So I'm just going to tuck that back in there. We've got lots of time now. That tissue will stay retracted for a while, but we're just going to do another impression, and with putting a gauze in between the teeth on the other side, just to have a little bit of separation so that we don't have so much displacement of the material occlusally.
So basically what we notice in the lab is doctors that do, we have associates that are saying, I got to work with what I got. And they're working with a plastic disposable tray. And those are the things where they're like sometimes loose noodles if you've got a Bruxer that has got flat teeth. So at the end of the day, what we like to help us, use a 2x2 gauze on the opposite side of the arch that you're actually taking the impression, and it creates a separation and a stable impression. So that's what Dr. Larsen's just going to do here now.
So everything's all the same. Tracy's filling the tray. I'm just going around the margins with the light body material. And then before we put the tray in, we're just going to put that on the other side and then just bite together. So that'll just create a little bit of occlusal separation. So you can see when I put that tray in there, it wasn't on the buccal surfaces. The material was away a little bit, so I was just able to put that in and make sure we're recording those buccal surfaces with the impression material. So you just stay closed on that now. I'm going to do the first part of the trimming of this temporary on the wheel. So I've trimmed that roughly on the wheel, and now I'm just going to do the final trimming of the margins of this temporary. So you can see that blue mark that I made earlier interproximally is still there. So I know I'm not going to trim that away because I know that's where it's going to be the most critical fit to keep the contact.
These are nice formed teeth, but when you have a real Bruxer, you're going to see a real solid press through the impression material, especially if you have a little thicker cotton swab. And what that does is it creates an incredibly inaccurate surface for occluding teeth to. So I just really want to point out the importance of why we're doing this process of a 2x2 gauze separating the other side, because if you have that situation, it creates like a mil and a half of impression material between the teeth. And we actually prefer that you do that regardless, because it always gives the nicest formation of tooth, and we're not pouring stone to a felt that is inaccurate. We can work with it, but if you have the opportunity to do it, it's the best. And then, of course, we have a nice bite record here of the prep and adjacent tooth. And again, if you hold this up to the light, you'll see that there's no shine through, okay, with the bite record. But if you see actually a white halo shining through it, that means you do not have a mil and a half. And at that point, we suggest you go back in, take a little more off if you can, or give us an option of either reduce the prep because it's a non-vital tooth, or maybe adjust the opposing if it's a vital tooth. Really, really important point to give us that information so that we don't have to stalk you down and find out which option we can do or what's the best one. Now you can see the difference here between these two. Now I am going to say I did see Dave wiggle this around a little bit when it was first set, and you can actually see that portion that is not to the tooth form. But the most important thing is there's no felt shine through on this, and that was just using the 1x5 or the 2x2 gauze on the opposite side of the arch. Both impressions we can work with. Obviously I'm going to pick this one all day long, but for the accuracy, But yeah, no, I think this will be a successful, very successful case. Okay, now we got Tracy
Just checking the
double
bite.
checking the bite after Dr. Larsen trimmed it in. And about to cement that temp. Nice broad contact. And pinpoint occlusal contact. Not looking
Yeah.
for any rise
That's-
on the temp.
No, that's perfect. I think we'll just leave it as is and then check it once it's cemented. Check the margins here. Yeah, that's fine. So marginal fit is good. It's a little bit high right at the contact area, so I'm just going to adjust that a little bit out of the mouth, and then we'll. Oh, we don't even need cement. There we go.
Yeah.
Friction fit.
Yeah.
Until you have that talking.
So Dave, just for the record, the second cord did come out with the
Yes.
last impression.
Okay, perfect. Thank you.
And which temp cement are you traditionally using? Kerr?
Temp on.
Okay. And that's with or without eugenol?
None.
No,
Non-eugenol.
non-eugenol.
So I just hold it in place for a minute or so, and just before I check the occlusion. I usually check the occlusion first, let the cement fully harden, get the bite together, and open again. You can see we've got a little bit of a heavy contact there. I might just reduce that a little bit. I can tell that the 6 is contacting, but I don't want too much on the temporary, so I'm just going to touch that up a little bit. And it's because of this nice cuff down here, so when we get the crown back, depending on what the occlusal situation is, I might opt to just do a little bit of adjustment of that lower sharp cuff there if we do have occlusal issues, rather than adjusting the porcelain.
Yeah, they can act like chisels for sure if you got a sharp
Yes.
cusp in.
Yeah. So we'll just clean up this cement.
I also want to encourage too that big cusp fossa relationships are not really a good idea on mold for temporize. Do you want to speak to that at all, Dave? Like, I don't know, do you take it down a little bit more than what it would be?
I kind of flatten the occlusion a little bit so that in excursions you're not going to bash the temporary off.
Right.
So, and it's not that important. As long as you've got occlusal support in the temporary, that's enough.
Yeah.
You don't have to have a lot of intercuspation to support that tooth temporarily. It's more comfortable for the patient too.
Awesome.
You're not going to have any interferences that you don't want. So I think we're pretty good. Everything's all cleaned up, and the temporary looks good. And how does that feel to your bite?